Today we will speak about tumors and tumoral conditions of pleura and also the chest wall. Pleura, as you know, is the covering of the lungs on either side, and it has got two layers: visceral layer, which covers the parenchyma of the lung, and then of course outside side is the parietal pleura, covers costal, mediastinal, and diaphragmatic surface of the thorax. So parietal layer is the outer layer, visceral layer is the inner layer. In between, normally there may be about 5 to 8 cc of fluid, normally. When it is increased, we call it pleural effusion. 2 to 10 cc of fluid is normal. Rich network of lymphatics is present in between the pleura. Now we come to the tumors of the pleura. There are primary tumors, namely primary neoplasms of the pleura, and then of course then the secondaries are the metastases, where the carcinoma is elsewhere in the body, whether in the lung, breast, prostate, etc. And among the primary tumors, mesothelioma is one of the most common tumors of the benign tumors of the pleura. Then can be benign, they also can be malignant. And benign, again, morphologically two varieties, local or diffuse. And then, of course, other tumors like lipoma, sarcoma, which are rare, but still one can encounter in the pleural pathology. Now, PA on your left-hand side and lateral on the right-hand side. You see a smooth mass silhouetting the left cardiac border. Part of it is behind the heart, retrocardiac region, a smooth mass. Now the problem is it in the lung? There is no air bronchogram. Is it in the pleura? Is it in the mediastinum? Is it from the heart? Obviously, it's not from the pericardium or heart. So by eliminating, it is in the pleura. This is the localized pleural mesothelium. And as you see, like meningioma arising from the meninges and getting into the brain with a covering, pleural mass also can go into the lung, not affecting the lung. There is a capsule and the pleural mass is along the costal margin. Another example of a pleural mesothelioma, here it is a little lobulated elderly male who happens to be working in the asbestos factory. Pleural tumors, either benign mesothelioma or malignant mesothelioma, are more common amongst asbestosis workers. And here, if you look carefully, there may be a small calcification of the pleura on the right side, and then a lobulated mass in the retrocardiac area. Again, oval, no calcification is seen, and it is again proved to be mesothelioma of the pleura. Again, just a cross-section of the chest, because today CT is so common in the investigations. You can find out, say, extrapleural lesions where you can get an obtuse type of angle along the corners, and parenchymal lesions, acute angle, and of course some of the pleural masses also you can see. Loculated pleural effusion also may simulate tumors, except they have got a lenticular type of shape often. Here, this is diffuse mesothelioma. Look at the PAV of the chest, right side, it simulates pleural effusion with a mass, and then CT definitely shows a mass, not only a mass, involvement of the pleura at the periphery, scalloped margins, diffuse, spreading mesothelioma. Again, it is localized. One more, mesothelium of the pleura extending to the major fissure, without obvious pleural effusion. The right costophrenic angle is clear. It is a pleural mass. Again, another case where it is a rounded, well circumscribed mass in the lung. Is it primary? Is it metastasis? Is it pleural? Again, it is pleural based. How can you tell? Because it is abutting, the longest diameter is abutting the thoracic cage and pleura. And on CT, you find necrotic areas, multiple necrotic areas in the center. Again, mesothelium of the pleura. This one It looked as if it is a chronic pleural effusion with elevated left dome of the diaphragm, slight shift of the mediastinum to the left, and pleural reaction along the periphery. And there is a mass again in the retrocardiac area. On CT section you could see part of it is pleural effusion, diffuse, and not only pleural effusion, the pleura, the so-called thickening in the pleura is a little scalloped. The pericardium is also involved. This is malignant mesothelium. Notice the mediastinum is fixed because although there is a space occupying lesion on the left side, because the invasion of the mediastinum is fixed. That is a primary radiological diagnostic point to think about a malignant mesothelium of the pleura. Because supposing it is a lung mass with involvement of the pleura, then because it is a space occupying lesion, the heart and mediastinum should be shifted to the contralateral side. Another lobulated mass. Lobulation is another characteristic of a pleural mass. Sometimes you may see a bunch of grapes along the pleural margin, indicating diffuse spreading mesothelium. Frankly, at times it is difficult to note purely on radiological grounds whether it is a malignant mesothelioma or a benign mesothelioma. Often localized mesotheliomas of the pleura, which are benign, are well delineated, whereas diffuse benign mesothelium of the pleura is rather difficult to differentiate from malignant pleural mesothelium. Here again notice a rounded mass in the right lower zone, wizard zone, because not in the lung, and lateral views also showed it is a pleural based, and it proved to be, although we diagnosed radiologically as a localized mesothelium of the pleura, it proved to be pleural sarcoma, which is a rare entity but can occur. And now, to simulate this or to differentiate mesothelial pleural tumors, loculated pleural collections may be present. Sometimes they are vanishing. In other words, for example, take congestive heart failure. There are loculated pleural effusions, and with treatment for the heart condition, they disappear. That's why they are also called vanishing tumors. Typical example, a PA and a lateral view of the chest. Notice the oblong, lenticular shaped opacity in the minor fissure area on the right side, and also in the right cardiophrenic angle area. Whereas in the lateral view, it shows it's not in the minor fissure, it is loculated in the superior port of the major fissure and also in the inferior portion of the major fissure, oblique fissure. So two loculations. Obviously the transverse fissure is not involved because it is only pleural thickening. Another example of loculations. Here you could see PA and lateral views. The cardiomegaly is there, congestive heart failure is there, and loculation of the effusions in the minor and major fissures. Usually these loculations which appear and disappear, so-called vanishing tumors, are more common in congestive heart failure or chronic renal disease with involvement of the heart. Another example of loculated effusion, both in the minor and major fissures. Right minor fissure, which is not seen well here, whereas in the left oblique fissure you see the loculations. Another, just to show in the oblique fissure loculations of the pleura, how they simulate lung pathology on the PA view. Unless you take a lateral view, you cannot definitely diagnose loculated pleural effusions. You don't have to have a CT. Just a lateral view is enough. From the morphology, from the shape of it, the lenticular, ovoid, in the region of the fissure, you can safely diagnose that is loculated pleural effusions. Just a diagrammatic representation of a pleura, oblique fissure in the lateral view and in the PA view, how it simulates the transverse fissure. Another pleural effusion, but again notice, if there is all pleural effusion, the heart must have been shifted to the contralateral side. Few scattered fibrotic infiltrates are there. In the lateral view, it is all located posteriorly. This is a loculated pleural effusion. Chronic empyema, in other words. Occasionally, there could be loculations in the mediastinum also. Look into the anterior mediastinal space, obliterating the cardiac silhouette and also extending up into the pre-tracheal area. This is loculated mediastinal pleural effusion. Again, this is characteristic of a encapsulated pleural effusion or empyema. How can you differentiate between effusion and empyema? Radiologically, it is not possible. I mean conventional radiology. Whereas in CT, by measuring the numbers, attenuation factors, you can differentiate whether it is a pleural effusion, simple pleural effusion, serous or serous angles, or empyema with thick pus. In a CT, again, you see the loculation. In a PA view, in fact, Dr. Felsen has described this as a profile of a pregnant woman's abdomen. Look at the obtuse angles at the corners. Again, another loculated effusion with calcification, chronic empyema. CT only showed that calcification. CT is better than PA and lateral views of the chest because it shows the calcification which may not be seen on conventional radiographs. Another loculation in the right lower zone. And in the CT, again, I emphasize, CT is essential to demonstrate the small cavity and also calcification. This calcification, chronic empyema doesn't mean it is healed completely. At any day, any time, it can flare up, either with superimposed infection or with the same infection with which the original effusion has occurred. So this is again calcification around the capsulation, encapsulated empyema with calcification and air fluid level because there is a superimposed secondary infection. Nobody has tapped this effusion. Occasionally, when a physician taps this effusion, he may introduce inadvertently some air. Then you may see this. But this patient never was tapped, and this is prima facie case of a secondary infection of a loculated empyema. Another loculated empyema in the posterior area. But sometimes you see you have to be very careful in the diagnosis. The obtuse angles are there, but sometimes, say, a hydrated cyst may simulate this. A carcinoma of the lung, a solid carcinoma of the lung, which takes a round shape, may simulate this. In old days, say this is a picture from 1949, when I started my radiology, in the beginnings of radiology. They used to treat tuberculosis with plumbage. Open up the intercostal space, introduce paraffin, sometimes lucite balls. This is one of those cases, chronic plumbage. Sometimes it may completely calcify, or only the periphery can calcify. Another case of plumbage, note the entire thing is calcified. Somebody has tried to put a tube. That's why that lucency is there. Drain the empyema, loculated empyema. In the PA view, the cardiac size is almost within normal limits. But in the lateral view, we see the pericardial fat. It's not pleural thickening. In a PA view, if you look at the right cardiophrenic angle, it is obliterated, as though there is something there in the right cardiophrenic mass. And the cardiac apex is also not well seen. This is not uncommon. Cardiac apex not well defined is often due to pericardial fat pad. Whereas right cardiophrenic angle may have a pericardial fat pad, but after steroid therapy and obesity and diabetes, it may accumulate and simulate a mass. And CT certainly shows that this is fat. Pleural fat. Earlier, you remember, in the Neoplasms of the pleura, we said lipoma also is one of them. But in steroid therapy, in a chronic renal failure, how do you know? There is a cardiomegaly, left ventricular hypertrophy. The patient had steroids, some fractures of the ribs are seen, and there is fat accumulated along the pleura. Extra pleural fat or pleural fat. Now, extrapulmonary lesions. We are talking about the tumors and tumoral conditions of the pleura and chest wall. And for example, here, chest wall. And the PA view, it all looks dense, bilateral, symmetrical type of breast. But in the lateral view, if you look carefully, there is a calcification. It is so rounded, looks artificial. This is a synthetic implant of a breast implant, which may simulate pleural masses and PFU alone. And occasionally it may be infected. That silicone breast may be infected and produce a air fluid level. These are the bilateral air fluid levels in an infected breast implant. And on occasion, you don't have to take a CT, but in a carcinoma of the breast, on a breast mass, you want to know whether the rib is involved or the pleura is involved or the lung is involved. In such cases, CT helps a lot, and here you see the breast mass. Another breast mass, and occasionally you may also demonstrate nodes. And not only there is a breast mass, there is a small metastasis along the pleura near the parasternal area, where the internal mammary artery goes. At that area, you see a metastasis from carcinoma breast. Now, in a PFU, the look appears that there is a mediastinal mass. Ovoid, we can't tell whether it is extrapleural, intraparenchymal. In the lateral view, definitely it shows there is a lipoma on the back. So, unless you are aware that extraneous masses on the skin, neurofibromata, lipomata, sebaceous cysts, can produce an PFU simulating a mediastinal mass, you have to take a lateral view to demonstrate it. Infections of bone. Why infections come into the tumoral conditions? Because it produces a mass again, simulates a tumor. Look at the PFU of the chest. There is an infraclavicular area, there is a rounded density, which you have to look carefully. Is it a coin lesion in the lung? Or is it pleural mass? So, if you look at the rib carefully, there is some osteolysis. On the CT, it shows well that there is a mass, extrapleural mass, and the low attenuation area in the center, and the rib is costochondral junction is partially destroyed. This is proved to be tuberculosis of the rib. Again, you look at carefully, there is a pleural, simulating a pleural ovoid mass at the periphery. But if you look at the rib, there is partial destruction. Again, this proved to be tuberculosis. Why I am emphasizing tuberculosis is, tuberculosis, first thing, is common in our country. And two, when it involves the ribs or costal cartilages, it produces an extrapleural mass, simulating a pleural mass. So it is a tumoral condition. Again, sternum, tuberculosis of the sternum, marked lysis, scalloping, and there is an extrapleural mass along the retrosternal area, going all the way down to the diaphragm. Tuberculosis of the sternum. Again, the patient came with an enlarged breast, thinking that it may be cancer. Here, you find in the costal cartilage, there is a soft tissue mass. There is a destruction of the mass, pushing the breast forward, simulating a breast mass. And that proved to be tuberculosis again. Another rounded mass, simulating pleural or parenchymal mass, and it proved to be tuberculosis of the rib again, producing a cold abscess. Now we come to other infections, such as actinomycosis. The triad of diagnosis for actinomycosis is 1, involvement of the lung, parenchymal lesion, which you may find here with a few air bronchorrhea. 2, pleural involvement. 3, bone involvement. Pleural involvement is abutting the pleura. And not only there is fibrosis, that's why the heart and mediastinum are shifted to the right. And if you look at the ribs and compare with the normal ribs on the contralateral side, they are thickened, slightly irregular. So, thickening of the ribs, irregularity of the lower margins, pleural involvement, parenchymal involvement, chronic condition, actinomycosis of the lung and pleura.